Dr. Cass, are you able to hear me?
Yes.
Hi, it's Daniela from Neil Road. How are you?
Very well, thanks. How are you?
I'm doing well.
Good.
I had a quick question. Do you know who should we contact regarding claiming the Project Echo as CMEs?
We will. He's sitting right here. They're actually both sitting right here. Either Troy or Chris can help.
Okay. And how can I contact you guys?
You have contacted them.
Okay.
They're listening.
Being contacted.
So, what, Chris, probably just Project Echo email?
Yeah.
So yeah, you can just email us. It's projectecho@med.unr.edu. And we can give you all the information on claiming your CMEs.
Perfect.
Yeah, should be no problem.
Thank you so much.
You bet. Good morning, everybody. Snowing a little bit in Reno this morning, so you'll probably be getting it in Elko this afternoon. And lots more snow coming, so a lot of excitement. We have a couple of really interesting cases to talk about this morning. Sue Holscher from Arizona submitted a case, but I don't think she's joined us yet. So I think we'll hold that case off. And in addition, Peg has submitted a patient by email that I think is a great case for discussion. And in a minute, I think Peg will get to discuss your case. And I'll give a short review of subclinical thyroid diseases. It'll be the definitive discussion of that topic, I hope. Because not a lot to say, and I think I just want it to be really clear, because I think this is one of those clinical challenges that comes up often in practice, and I'm hoping to give you guys some solid information that will help you manage this fairly common clinical occurrence. So I'm going to take this opportunity, though, to introduce an old buddy of mine who's joined us from the East Coast this morning, Ken Kamler. Ken and I trained simultaneously 112 years ago, and have been friends for probably going on 40 years now. And the reason Ken is joining us, just so you all know, is that we have this idea to start a wilderness medicine echo program. Ken is a physician who's practiced in some of the most extreme environments on the planet, and working together with one of our faculty members, Tony Islis, who's a former president of the Wilderness Medical Society. These two guys are hoping to create an echo program that could conceivably help support first responders and physicians and other healthcare providers working in the wilderness, whether that's the National Park Service, the U.S. Forest Service, or elsewhere. We thought ECHO would be a great platform. So we wanted to give him an opportunity to see kind of how this all works. So nice to see you again, Ken. Thanks.
Thank you, Evan. Thanks for welcoming me.
So, Peg, do you want to tell us about the patient who you were concerned about?
Let's see.
Just remember, we're no reveal of protected health information.
Okay. Can you hear me, Evan?
Perfectly.
Oh, good. Okay. I was thinking we were presenting in 2 weeks, so as usual, I'm not prepared.
That's okay.
But this is a 19-year-old man who came in for a routine physical exam. He works for the county here. he has a mother who has type 1 diabetes. I took some of the standard labs, and he had not eaten, I believe, in about 12 to 14 hours. He was fasting, and his fasting glucose was either 36 or 39. So I talked with you about that. You made some recommendations of labs that you did think this should be pursued, that this was just not a normal hungry young man. I've been a little bit stymied because he currently has no insurance and he can't afford the labs you recommended. So I think he'll have insurance in about 2 months. So my thought at the moment is to prescribe him a glucometer and talk to him about balanced meals and try and keep him in line until we can get more information.
Okay. Thanks, Peg. So just tell me what he looks like. Is he thin? Is he heavy?
He is thin and tall enough that I sort of considered Marfan's.
Okay.
He's got a couple of interesting bony situations. He's got the most pointed chin I have ever seen in my life. He looks like a great big elf.
Okay.
He also has scoliosis, reasonably severe. No sternal abnormalities. I tried my little favorite test of bending the thumb back, and he's not especially flexible or anything like that.
Okay. Is he fully virilized?
Is he what?
Is he fully virilized? Does he look like he has completed his pubertal development? Full beard?
Yeah, I think so. That's a good question. He might be a little short of beard.
Okay. Is he, so you probably don't have this, we seldom get this information. Is he taller than his parents?
Haven't seen his mother in a while. She was pretty tall.
Okay.
I don't know about his father,
Okay.
but he might be.
Okay. So, the thing that I always think about in young people who have metabolic abnormalities is whether this abnormality is part of a syndrome. And so, but I'm going to put that off on the side for the moment because I do want to talk about the evaluation of a patient with hypoglycemia, because I think this is really, really important. There's an opportunity to miss something bad, but it's a challenging diagnostic problem. So just remember that the body's defense against hypoglycemia is extremely potent, right? Hypoglycemia puts us at extreme risk because our brain is incredibly dependent upon glucose for its metabolic function. So we defend against hypoglycemia really well with a whole palette of counter-regulatory hormones, right? Between glucagon, norepinephrine, and growth hormone, and cortisol, we've got a lot of protective neurohumoral mechanisms. So when glucose falls to such a low level, and to me, values below 50 really raise my antennae. I'm starting to really worry that there is something significant going on. So 36 is an important value, and it requires investigation. This can't be blown off. Now, could it be lab error? Of course, anything could be lab error, but I think we have to take it seriously, and then we have to say, all right, well, if the blood glucose gets to 36, how does he handle it? Is his brain working? Most of us, when our glucose levels decline, start to get symptoms, right? But the symptoms we typically get are adrenergic activation, right? We get hungry, sweaty, tremulous, anxious. We may feel, palpitations, all of those manifestations of adrenergic activation. So, and typically when our patients tell us, oh, I feel like I'm hypoglycemic late in the afternoon, those are the kind of typical symptoms that they get. Patients who have severe or serious underlying etiologies for hypoglycemia often don't get those symptoms because their bodies have become habituated to these low sugars and that adrenergic activation stops happening. But what are they getting? So they get a set of symptoms that we call neuroglycopenic symptoms, right? Lack of glucose to the central nervous system. And what are those? Well, they tend to be confusion, disorientation, memory lapses, bizarre behavior, seizures, motor vehicle accidents, things that indicate that the brain is not working properly. So I would wonder how this fellow felt at the time his blood sugar was 36, because if he didn't have adrenergic symptoms, that would suggest that this is a problem that has been recurrent.
Right. Actually, he looked pretty good that day.
Okay.
I didn't guess anything was wrong. When I discussed the lab results with him a week later, he mentioned that he does occasionally feel very low, and he's part of a responder team. He uses their glucose checking at that point, and usually eats something. So he's somewhat aware, but he wasn't looking bad that day.
Okay. So what kind of numbers do they find when they test him in the field?
I didn't pin that down, but I think probably around this point.
Okay.
But I'm not sure.
So this bespeaks a serious problem. And the sorts of problems that one needs to think about are insulinoma, right, which would be the most common cause of endogenous hyperinsulinemia. Insulinomas tend to occur later in life, but there's no reason that it couldn't occur at such a young age. And the only way to know that is to measure insulin simultaneous with hypoglycemia. Okay, so measuring insulin when the patient is euglycemic is useless because, as in everything with endocrine, it's all relative, right? So you need to see, is the insulin level appropriate to the blood glucose level? So without that bit of information, we are stymied, right? All we can do basically is say, well, you better eat something, and maybe you better wake up in the middle of the night and see what your blood sugar is during the middle of the night. So we can treat him in a sort of prophylactic way, but recognizing that there's the potential that this fella has something seriously wrong. So insulinoma would be the most common etiology for this sort of hypoglycemia. However, there's a kicker here, and that is that his mom has type 1 diabetes, right? So that means there's insulin in the house. And where there's insulin, there's the potential for surreptitious insulin use. And people do things like that for all kinds of reasons, right? For attention, for secondary gain of one sort or another. There's just a whole literature on why people do those things. And I'm not saying he's doing it. I'm only saying one needs to consider that possibility. So
He is now living about 60 miles away from his mother, so that would make it less likelihood. It wouldn't rule it out. He could visit. But...
Okay, absolutely. So I think the thing we need to do here is try to, at the same time that we measure his insulin and glucose levels, we should try to exclude the possibility of surreptitious insulin usage. And there's a way of doing that, right? And the way we do that is to measure serum C-peptide at the same time that we measure insulin, right? Just for review, C-peptide is secreted as part of insulin. It's cleaved off, and it's secreted in an equimolar quantity. That is, there's one mole of C-peptide for every mole of insulin, right? So if one were to measure insulin and C-peptide was not elevated at the same time, that would support exogenous insulin injection. and would rule out endogenous insulin secretion. So we need to get that too. And obviously there are other causes of, there are other drugs that are used surreptitiously. Sulfonylureas, for example, can raise both insulin and C-peptide levels. So, but I would say in this scenario, that's much less likely.
Okay.
What is the, Dr. Klass,
Yes,
what is the range for, the normal range for C-peptide?
I have no idea.
Oh, yeah, I can't remember either.
Yeah, I don't know.
Okay. But if it,
There's certain things I can remember, and there's a lot
I
of
think
things
it's
I
1 to 3.
1 to 3. Okay.
Yeah.
would you repeat that? If it's elevated, would you go through that little thing again? If it's elevated,
Remember, so just think about it this way. Insulin and C-peptide, if they're coming from the pancreas, should move in the same direction, right? So there should be an equivalence between those two things. And if C-peptide is suppressed while insulin is elevated, that would point towards exogenous insulin, right? Because there's no C-peptide in exogenous insulin. So it's critically important to do that. Now, there are a whole other set of possible etiologies. There are certain genetic syndromes that cause endogenous hyperinsulinism. We have a kindred in Reno that we discovered where the dad and 2 children all have recurrent hypoglycemia with endogenous insulin production. I thought the dad had an insulinoma when I first met him, sent him to Stanford for surgery, and lo and behold, he didn't have an insulinoma. And then all of his kids turned out to have it, and they've got a defect in the insulin receptor gene where insulin continues to be secreted. So that's a rare bird. Much more common are the scenarios that we're talking about here. Now, the reason I asked about pubertal development is, could he have something else, right? Could he have adrenal insufficiency? Could he have hypopituitarism? All of those things could cause recurrent hypoglycemia. So the way we would evaluate for that would be to check the rest of his pituitary function. Does he have a normal free thyroxine? Does he have a normal morning cortisol? Does he have a morning testosterone? And those you can do even with a normal blood sugar, right? So those don't have to wait until you catch him at a moment of hypoglycemia. But to assess the appropriateness of insulin secretion, you got to do that when he's hypoglycemic. So how do we do that? Because it's not always easy, right? It doesn't happen all the time. What I do, in the old days, we would admit patients to the hospital, right? And we would fast them in the hospital and watch them. And eventually they get hypoglycemic, right? You know, everybody with an insulinoma, if you fast them for 48 to 72 hours, eventually gets low. Can't do that anymore. So now we have to do something that's less reliable but cheaper. So generally what I would do is to have him fast from bedtime or from dinner, and I get a sense from him how long he can go before he gets low. And then I would have him come to the office first thing in the morning, and I would do a finger stick blood sugar, and then I would have him hang around. And I might send him out for a walk and do something that would deplete glucose. So try to drive his blood sugar down. So fast him for as long as you can, keep checking his blood sugars, and hopefully eventually he gets hypoglycemic, and then you can get all the testing done that you need to do. So it's a bit of a provocative test. You need to take some precautions, obviously, that he doesn't kind of end up in the parking lot seizing. So you want to just be sure that you've created a safe environment to do this. But that's, I think, the best way to do it. You agree? I think it's kind of how we would do it in practice. But you need to be prepared for when he gets hypoglycemic. So that could be when he's symptomatic and when your finger stick blood sugar supports it. And you may want to finger stick him twice just to be sure, because it's so critically important that his blood sugar truly be less than 50. Otherwise, the results are not going to be interpretable.
Okay.
It's a lot of work for you, Peg. I'm giving you a big job here.
Yeah. Considering that he goes quite low, will just under 50 be low enough to get the results you want?
Yeah, because at that point, insulin should be undetectable.
Okay.
Okay, and that's really the point, that at a certain level of glucose, there should be no circulating insulin, right? You should have turned off all endogenous insulin production. And that's the point that you want him to be. You want him to be at a point where you kind of know where his insulin should be. If it's 60 and his insulin level is lowish or highish, that could just be insulin resistance, But when he's truly low, he should have no detectable insulin for all intents and purposes.
Okay.
Okay?
Okay.
All right.
Thank you.
And
Actually, Evan, one more question.
you bet.
Since he cannot afford these tests for a couple of months, are you suggesting a glucometer, balanced meals, maybe get him to wake up in the middle of the night and recheck? Anything else?
I would treat him the same way we would treat a patient with diabetes who's got, hypoglycemia insensitivity, So that is frequent glucose monitoring, bedtime snack, and maybe middle of the night glucose just to be on the safe side.
Okay.
The other thing you could, of course, do would be, put him through his paces, get his blood, get him to the office, get him hypoglycemic, draw his blood. You could spin it down, you could freeze his serum so that at the point that he has his insurance, you could submit his specimen. But it's a tall order. I'm not, but it might expedite things once he actually is insured.
Okay.
Okay.
Great. Thank you.
So is he in Idaho or is he in Nevada?
Where is he in Nevada?
No, is he in Nevada or Idaho?
Nevada.
Nevada. So, and he's not a candidate for Medicaid, considering our Medicaid expansion?
No, I don't think so, since he's working.
Uh,
He did say the other day that he's been pretty close to starvation for a couple of months before he got this job. Yeah, he's been eating mainly ramen noodles for a couple of months. And then when I saw him, I guess this was the employment examination. So I don't know if that would have affected this at all.
it's almost impossible to starve your way to hypoglycemia. I don't think that we need to consider that as a possibility. That would be, that would truly be extraordinary.
Okay.
Right. So is Sue Holscher here? No? Okay. Yeah, Jan, question.
Would glucagon work with him? Glucagon, if he was really seizing, let's say?
That's a great question, right? Because what does glucagon depend upon? It depends upon hepatic glycogen stores, right? Glucagon mobilizes that. If he were truly starving, might not work. Nothing in the tank, as Veronica said. I think that is, the potential is there, but I don't think that it's not likely to be the case.
Do you have patients that do keep those kits? Do you find it practical to have the patients, renewing their kits? And maybe Veronica, I don't know. My son has type 1, and it came up in my mind whether I should encourage him to do that. I don't even know if he has one, but.
I usually encourage it. I primarily encourage it in my college kids, because those are the ones that I find get into more trouble. So they
Drinking.
will, yeah.
Drinking will not.
They don't drink at all. No, it doesn't happen.
But that's the population that usually gets into trouble. So I really encourage it in them. For kids, well, I don't see a lot of kids that live at home, but for people who are kind of more responsible, don't usually have, and I always evaluate whether they've had episodes of severe hypoglycemia. If they haven't had episodes, I'm not as pressed about it, but college kids, absolutely.
Yeah.
If you do drink, though, and pass out, it doesn't work that well, does it?
That's right.
So there's a problem there. I just have to.
It's another one of those areas where, best practice certainly is to prescribe glucagon emergency kits. Typically what happens is when we've seen a new patient, we we make sure they've got their glucagon emergency prescription. They fill it once, it sits in the medicine cabinet, it doesn't get used, it expires. It's a difficult scenario. Should they have it? Of course. Of course, they also need someone around who can administer it, so somebody needs to be trained to provide it. But yeah.
And for the folks that are way out in the rules, so I have some people kind of living off grid, those folks, I'm sure to prescribe it for.
Yeah.
Thank you.
So maybe we'll change gears, and maybe it was the weather that prevented Sue from joining us, so I thought we would talk about subclinical thyroid disease, just as a review, and in the interim while I'm gabbing away here, if anybody has any other cases they want to talk about, feel free, and we can, because this, I'll be relatively brief. We'll have time at the back end. I see a hand in Wells.
Hello. I have a thyroid case that I wanted to discuss, but never got it together enough to send the paperwork. I'm sorry.
Can we, do me a favor, can we hold, let's just hold that, let's do this talk and we'll get back to your case.
Perfect.
We will do it. Okay, so this is a subclinical thyroid disease. The question is it something or is it nothing? And I think it's something, but I don't think it's a big thing, is the long and short. We can stop now. What we're really talking about here are a set of lab abnormalities that are a fairly common occurrence. So let's talk about subclinical hypothyroidism first. So how do we define it? Well, a TSH above normal, so typically most labs, the upper limit of normal is about 4.5. And I think most experts would say that a value above 10 micro-international units per ml is clearly abnormal and sort of speaks against a diagnosis of subclinical hypothyroidism. That TSH, should it rise to that level, the patient's got symptoms. Whether they're describing stuff that we recognize as hypothyroidism or not, those patients are hypothyroid. It's the patients in between. So from the upper limit of normal to about 10, where we get into some degree of question. And further, these patients have a normal free T4, so they're able to generate enough thyroxine production to meet our standards of normalcy. So their free T4s are, say, somewhere between 0.9 and 1.2, depending upon your lab. Those two measurements define subclinical hypothyroidism. There's no added value, and there's loss of value by measuring T3 or free T3 in those circumstances. Think about it this way, and this is not all that scientific, it's a bit teleologic. When the body is beginning to become deficient in hormone production, it tends to shift the equation towards the more potent hormone. So as T4 production declines, the body tends to favor production of T3. So T3 levels can be anywhere in the setting of subclinical hypothyroidism, and a low value is not particularly helpful in proving the diagnosis. A normal or even slightly elevated value is of no value in disproving the diagnosis. So typically what happens is we're measuring TSH as a screening. We find, the TSH is 6. We want to make sure that the patient's not truly hypothyroid. We measure free T4, but don't measure a T3. Under those circumstances, it doesn't get you anywhere. So what could cause it? Well, anything that could cause hypothyroidism could cause subclinical hypothyroidism. And of all of the causes of hypothyroidism, of course, Hashimoto's thyroiditis is most common. Now, patients can have an atypical set point so that they could, they could have a TSH of 5 as their normal set point. Remember, the normal range defines 95% of the population, right? On either end of that bell curve is 2.5% on either end. So a TSH of 5 could be normal for that patient. It may just be their normal set point. Anything that's injured the thyroid previously, whether the patient's had radioiodine for hyperthyroidism and has slowly failing thyroid function after that, or they've had radiation treatment for Hodgkin's disease, they've had mantle irradiation and have injured thyroidal injury, or if they've had a partial thyroidectomy in the past and the remaining piece of thyroid is not really able to keep up. So those are the possible explanations for this sort of biochemical picture. So what to do? Well, the first thing to remember is this is not an emergency. Nobody's going to get into clinical trouble because they've got a TSH of 6 with a normal free T4. So what we want to do is to take a deep breath and remember that if we initiate some action, that may be lifelong. So before we initiate that action, we want to be pretty sure we understand what's going on with the patient. We can always put the patient on treatment, but I think the important thing here is to slow down, figure out why those numbers are there, and then decide what to do. So what I would do is the following. First thing, I'd want to make sure that it's real. Now, at least 30% of patients who have these marginal TSH elevations are going to revert to normal in 6 weeks or so. So I would just repeat the tests at that point. I would reassess the patient for the presence of symptoms. Are they cold intolerant? Are they constipated? Do they have dry skin? And remember that all of those symptoms are there's a tremendous overlap between all the rest of us and patients with mild hypothyroidism. They're very nonspecific. But you want to kind of catalog them, because the more symptoms they have that are possibly consistent, the more likely they are to have hypothyroidism. They have 4 symptoms that are consistent with hypothyroidism, they might actually have hypothyroidism. Whereas if they have 1 or 2, there's no difference between those patients and normal. And you want to check TPO antibodies, right? You want to look for that marker of Hashimoto's thyroiditis. And so, but I would wait the 6 weeks. No reason to stick the patient. There's no urgency. Wait 6 to 12 weeks. Repeat the TSH, repeat the T4, and measure TPO antibodies. And then, based on that, if the TPO antibodies are positive, then the patient has Hashimoto's thyroiditis. And the probability is that what you're seeing is the early stages of the development of hypothyroidism. And if the patient was, had, 4 or 5 symptoms consistent with hypothyroidism, you might want to initiate a therapeutic trial. And of course, that means the addition of levothyroxine. And the goal would be to get the TSH down to 2.5 or less. You want to be sure that if you're going to treat, you're treating to some target. And I think a TSH down under 2.5 is a reasonable target to ensure that you have given enough thyroid replacement to satisfy the patient's pituitary. And then you can reassess for whether the patient actually feels any better. Sometimes they do. A physician buddy of mine who recently was found to have TPO antibodies positive at a TSH of 5, despite my suggestion that he do nothing, initiated levothyroxine therapy and says he feels like $1 million. So just goes to show you. But there's no harm in a therapeutic trial. There's also no harm in stopping a therapeutic trial. Once you've gotten the etiology, you can treat. If the patient says, I don't really feel any different, there would be no harm in withdrawing therapy and then monitoring the patient over time. And I would, that's completely discretionary for you all. So should have put this up sooner. So if the patient's symptoms are maybe thyroid related, maybe do something. Now, there are some correlates with subclinical hypothyroidism. These patients have a little bit higher LDL cholesterol level. Their CRPs tend to be a little bit higher. And the possibility that this is a modifiable cardiovascular risk factor has not been excluded. On the other hand, there's no data to show that thyroid replacement affects cardiovascular disease risk. So something to be aware of, but I don't think creates an urgency to institute therapy. Where do I modify my position? If I've got an older patient who's got coronary disease, or maybe has a bit of cognitive deterioration, I might be inclined to treat, okay? On the outside chance that maybe there's some gain, but there's no good data. So what about the other end of the spectrum? So subclinical hyperthyroidism. So here we're talking about patients who typically on screening have a TSH below the lower limits of normal, which is typically somewhere around 0.4 microinternational units per ml. Their free T4s are normal. Now in this case, I think there is significance to measuring T3 or free T3, because in this setting, T3 levels tend to go up sooner than T4 levels. And an elevated T3 or free T3 in the setting of a suppressed TSH would be diagnostic of hyperthyroidism. We used to call that T3 toxicosis, but that would be true. I would change that from calling it subclinical hyperthyroidism. I would call that early hyperthyroidism. And to me, that there is some urgency there. So a repeat of values and a measurement of free T4 and T3. So what can do it? Well, intercurrent illness is probably the most common cause of mild TSH suppression. So that goes away. So repeating the values in 6 to 12 weeks makes sense. It could be early hyperthyroidism, and the same etiologies that cause hyperthyroidism under other circumstances cause subclinical hyperthyroidism. It can be Graves' disease, nodular goiter, toxic adenoma. It could be subacute thyroiditis, typically a painful entity, but not always. Sometimes we see persistent low TSHs in patients who have had radioiodine treatment for hyperthyroidism in the past. T4s normalize, TSHs stay in that lowish range. We don't have a great explanation for why that is. We tend to follow the free T4 in those patients rather than the TSH. And the other big issue is that opioids will suppress TSH. So those would be the considerations. So what to do? So again, in the absence of symptoms, which is of course what we define clinical hyperthyroidism to be, there's again no urgency. Repeat the values. If it's an intercurrent issue, it's going to go away. TSH will probably revert to normal, and probably 30 to 50% of patients are going to revert to normal if they're asymptomatic. If the abnormality persists, then you're kind of obligated to do something. I like to do a radioiodine uptake because it's going to help me etiologically figure out what's going on. If there's diffuse uptake of iodine throughout the gland, I'm going to say, well, that's most consistent with Graves' disease. If there is patchy uptake, well, that's most consistent with nodular goiter. And if there's one hot spot in the gland, then that's typical of a toxic adenoma at its early stages of becoming autonomous. So a nuclear scan and radioiodine uptake, I think, is a good way to go. One could measure thyroid receptor antibodies as a marker for Graves' disease, perfectly reasonable to do that, but that's how I proceed. And then the question is what to do. In an otherwise healthy younger person with a TSH of 0.3, my inclination is to sit tight. On the other hand, my cut point is a TSH of less than 0.1. At that point, I think we're dealing with a real abnormality that has a certain degree of risk associated with it, and one needs to take action. So here are the reasons why you might. Well, the patient may have subtle symptoms, right? They may have some cognitive issues. They may have a heart rate that's sort of disproportionate to what you would expect based on age. and level of physical activity. They may have some muscle weakness. You want to protect the heart, right? Excess of thyroid hormone stimulation of myocardium is long-term not so good for you. We see that in echocardiograms where patients have abnormal myocardial function, so this is not to be left untreated for very long. The risk of atrial fibrillation goes up substantially as the TSH comes down. We know that bone loss is accelerated with suppressed TSH, and we want to protect from cognitive decline, especially in older people. So when TSH is persistently less than 0.1, regardless of age, I'll eventually do something. If the TSH is only mildly suppressed, sort of in that 0.3 to 0.1 range, then I'll eventually treat if the patient is older or if there's underlying heart disease or dysrhythmia or osteoporosis. So those are my 2 points for intervention. And the question is, what do you do? Well, this is one of those areas where joint decision-making is incredibly important because there's no right answer. If I'm convinced that the patient has a TSH less than 0.1, this is going to be persisting, I always prefer radioiodine because you get it over with, right? You do something definitive, destroy the thyroid, and you're not going to be confronting this issue in the future. Patients often resist that because it sounds horrible, and there's nothing wrong with a small dose of methimazole. And oftentimes 5 milligrams of methimazole a day will be perfectly well tolerated. Risks of idiosyncratic reactions are extremely small. Patients tolerate it well, and no harm with that therapy either. Questions? I see Sue has joined us, and we also we have 2 cases to talk about. But if there are questions about subclinical, I'd be happy to answer them. Okay. Oh, yes.
I don't have any notes or anything in front of me, but I've had a couple of cases where I get kind of bouncing labs that go either direction with the T4 or looking like a little elevated, and then the TSH going between too high and too low. Have you seen that?
So there are, yes, not a common scenario. The thing that I would be concerned about in that setting is that the patient has immune thyroid disease of some sort. And, I view Graves' disease and Hashimoto's as the same disease. And patients can have varying thyroid function based on whether they're producing thyroid TSH receptor blocking antibodies or stimulating antibodies. So we see that kind of flip-flopping some. So I would look for some marker of immune thyroid disease. I might measure TSH receptor antibodies in that situation.
Okay.
The bigger risk in those patients is when they get hyperthyroid. So when you need to treat, I generally would treat them when they're hyperthyroid and maybe do something definitive. Knock it out and then replace it. Sue, do you want to present your patient? And then we're going to loop back to Wells for your follow-up.
Sure. Can you hear me okay?
Perfect.
Okay. So this is a 43-year-old female that we've been seeing for about 6 months. She has the part that's kind of complicated, that our main question is the partial pancreatectomy. She swears she's taking her insulin doses. So she's got 90 of Detamir in the morning and at night, and then Aspart 20 before all the meals. So 3 times a day. She says she's taking it, but she does have some depression, and we have got her down to the A1C around 9, but that's the best, and now it's like 13.8.
Okay. So how come she had a partial pancreatectomy?
She said she went overseas. Her husband is from Pakistan and caught some big viral infection. That's how she explained it to me.
Okay. And how long ago was that?
2013
So
was
relatively.
the surgery.
And did she have diabetes before that?
Ooh, good question. I'm not sure.
Okay. So sometimes patients end up with a partial pancreatectomy if they've had a severe necrotizing pancreatitis, or they've developed a pseudocyst or something. You just can't be sure why that might have happened. It's obviously a horrific thing to do, and obviously, if you lose enough of your pancreas, you end up with insulin deficiency. You also end up with counter-regulatory hormone deficiency, right? So patients with pancreatectomy also lose their glucagon production. One of the things about these patients is that they tend to be exquisitely insulin sensitive. And hypoglycemia is not an uncommon event in these patients. They kind of bottom out with some regularity. So this sort of significant or substantial insulin resistance is a little surprising in that scenario. You agree? Has that been your experience? That these patients tend to be very insulin sensitive. The other thing that's interesting is that she's obese. Right? So patients with pancreatectomies oftentimes not only have loss of hormonal production, but they have loss of digestive enzyme production. Right? So they typically have steatorrhea. They tend to lose weight and need pancreatic enzyme replacement therapy. So the fact that she's obese, she does not have a need for pancreatic enzyme replacement, makes me think perhaps she didn't lose that much of her pancreas. And maybe she does truly have underlying type 2 diabetes, and she's pretty insulin resistant. So there may be nothing more to it than that. The pancreatitis that you reported, though, was that preceding the pancreatectomy, or has that been since then?
So since she's had the pancreectomy, then she's had multiple admits for acute pancreatitis.
Wow.
To the ER. She's always complaining of this abdominal pain.
That's
And it was truly pancreatitis. She had elevated enzymes and the whole nine?
That's questionable.
okay.
Yeah.
So it's epigastric pain, nausea, vomiting.
Right.
I'm sure that sounds like it, but does she have pancreatic calcifications? Anything that makes you convinced that she has chronic pancreatitis?
No, they didn't. They did like the whole scans and they said it looked good.
Okay. So pretty complicated scenario. I think that you have to treat what's treatable and say, all right, well, she's on big doses of insulin. It looks like she's got insulin resistance. Any reason that she couldn't be on metformin?
Man, I wish I had the doctor in with me. She might have been sensitive to it. I don't remember.
Okay. Certainly, if she could take it, it would be.
That would be a good addition.
That would be a great addition. If she couldn't take it with that degree of insulin resistance, you might even consider a small dose of pioglitazone if she couldn't take. If she couldn't take metformin, just to have an insulin sensitizer on board.
Okay.
Her TGs reported as 342, so that's not a level that we typically associate with pancreatitis. Usually we start to get nervous when the TGs are above 500 or 1,000. So,
It was before. It was at 1,000.
Okay.
And then
so that may precipitate pancreatitis. The best treatment, of course, is controlling her diabetes. That's the best way to get her TGs down. However, adding a fibrate would certainly be reasonable in a patient who seems to maybe have triglyceride-related pancreatitis. And a very interesting paper came out last week. It was an extension of the Accord study that looked at combinations of statins and fibrates. You know, the original studies made it look like probably there was no cardiovascular risk reduction with combination therapy, but this extension study made it look like maybe there is some cardiovascular protection from combination therapy. So adding a fibrate might be a reasonable thing to do, since it seems to me the most important thing is keeping her out of the hospital and keeping her comfortable. So
What do you think about the dose, 90-90, 20-20-20?
nothing wrong with it. It's a lot, you know, so I think you need to.
And she's gained weight, the 30 pounds, since like 3 months, since we keep upping it. She's just gaining.
Yeah, so what are her, you know, so I think you need to scroll back a little bit and go back to basics and say, all right, what the heck's going on here? You know, reassess her diet, make sure she's clear about what's appropriate and what's not appropriate. You know, is she drinking fruit juices? I mean, there are just a million things that need to be considered to ensure that that she's clear about what's right and what's not. And then she's probably going to need some kind of adjustable mealtime insulin schedule, right? To ensure, you know, you got a lot of basal insulin on board, but she's relatively light on the prandial insulin dose.
Mm-hmm.
So I think you want to reassess that. You know, she may just not be getting enough prandial insulin, but you know, goal should be less insulin as our first attempt.
So that was my thought as well, because she is on a lot of basal insulin. So depending on what her blood sugars are doing, I mean, if she's eating a lot and postprandial blood sugars are really high, you kind of ramp up on your aspart doses. And also to be sure she's not having any like overnight hypoglycemia, because she is on some fairly hefty doses of long-acting insulin. My only other thought with her, if she truly is needing 240 units of insulin or more, would be to potentially switch her to the U500, something that she could do 3 shots a day, and probably get some more, I like it for better coverage for some of these patients. So those are my thoughts about her. Ramp up on her mealtime insulin, kind of see what her blood sugars are looking like, and if she is requiring 240 plus, possibly switching her over to a U500.
And the way I would discuss it with her is to say, hey, you know what? This poor blood sugar control contributes to your high triglycerides, maybe precipitates some of these episodes of pancreatitis. That's probably a pretty good motivator for a patient. She may be amenable to some dietary intervention, good counseling. Try to get a sensitizer on board, whether it's metformin or maybe a little whiff of pioglitazone, maybe 15 milligrams. You know, obviously the weight gain potential with pioglitazone is something we'd like to avoid, but might be helpful. And I would seriously consider the addition of a fibrate to force her triglycerides down, again, to protect her from these fairly terrible recurrent episodes, which are, you know, maybe factored into her loss of a job because of these hospital admissions, etc.
True.
How come she's on gabapentin?
I didn't I mean, I'm the dietitian, but I am assuming the neuropathy. Thing. Yeah.
Right.
I tried to get him in here. He had a couple patients though. Shoot.
I hate when those patients get in the way. It really kind of takes the wind out of our sails. So I hope that's helpful. Anybody have any other thoughts about what we might do? So Sue, you're an RD?
Yes.
This patient is you don't need another professional. You got to handle this one yourself. It's this patient. Let us know what happens, would you?
Okay, thank you very much.
Okay, so should we loop back to Wells?
Sure. So I have a thyroid question for you. A 58-year-old female, Hispanic female. She does have Medicaid insurance. And she was diagnosed with hypothyroidism in Peru. And I started seeing her in June of 2015. So she brought me a lot of records from Peru. She was followed by endocrinology there, and they had recommended a biopsy based on a small nodule that was found, and they had initiated levothyroxine at 50 microns. She had declined the biopsy in Peru and ended up moving to the United States. So I repeated an ultrasound in June of 2015, and her thyroid gland was enlarged and heterogeneous, but without any nodules or suspicious calcification. So I ordered a repeat, and she never ended up doing that. I finally got a repeat. She had gone back to Peru, and she came back to me. I finally got a repeat ultrasound in December of 2016 with some labs on her. Her TPO was elevated at 106, and her most recent TSH in December was 4.8, and she was on levothyroxine 50 daily. So her current ultrasound shows that her thyroid is still enlarged, but she does have a hypoechoic nodule in the posterior aspect of the lower pole of the left thyroid that measures 0.7 by 0.6 by 0.7 centimeters. She declined a biopsy when I went over these results with her, but she was willing to increase her levothyroxine. She stated that in the past, when she was on 75 mics, that it caused fatigue, which I found interesting, but she was willing to do 75 mics on the weekends and continue 50s through the rest of the week. My question for you is, should I push harder for a biopsy of this nodule, this newer nodule, knowing that she has Hashimoto's thyroiditis and her TSH was above our goal is, where should I go with this patient? Otherwise, relatively healthy.
So here's my first question would be, do you have the report of her Peruvian ultrasound?
I do.
Where was the nodule that they mentioned located?
It was I'm sorry, there was no nodule in Peru.
No nodule.
No nodule.
Okay.
But they still recommended doing a biopsy.
Okay, so here's what we know about the patient. Apparently she was hypothyroid, right? In Peru, we don't necessarily know the numbers, but enough of an abnormality that her docs down there decided to add levothyroxine. So let's just presume that she did, in fact, have hypothyroidism. We know she has TPO antibodies, so we know she has Hashimoto's thyroiditis. And we also know that an ultrasound a year and a half ago or so showed a picture that was consistent with Hashimoto's, and that is heterogeneous echo texture, which is typical, right? Hashimoto's causes fibrosis and scarring and a lot of funny-looking things on ultrasound. What we often see is that when we repeat the ultrasounds, you get greatly varying reports from the radiologists. Because what happens is there's a tendency to overread these ultrasounds because you've got all of this fibrosis, and what looks like a nodule is really just a pseudonodule because you see some tissue between these fibrous bands, and it looks hypoechoic because the fibrotic areas are hyperechoic, so relatively it looks less echoic. So here's the thing. This is a sub-centimeter nodule, perhaps. We don't really know if it's a nodule or not, but it's less than a centimeter. In a patient who has another explanation for abnormal thyroid echo texture, I would, and you've got a patient who doesn't want to have a biopsy, who's had the good sense to fight back, to protect her neck over time, I would say that's great, right? Because, you know, some years back, they told her to have a biopsy, she didn't do it, she's still with us, and she doesn't have any large thyroidal abnormality. There's no indication for a biopsy here. She doesn't have microcalcifications in this possible nodule, and it's less than a cm. I think you are stuck, though. I think that you will need to repeat this somewhere down the road. I would try to get it repeated by the same radiologist who did it this time.
And that's,
I would wait at least 6 to 12 months.
6 to 12, okay.
Now, the issue of increasing her levothyroxine dose, yeah, it would be desirable, I think, to get her levels down. But if she feels fine, you know, I don't think I would force the issue. So my inclination is to just go with the flow here, but I would definitely, you're obligated to repeat that ultrasound. But you wait long enough for something to actually happen, right? Remember, 3 to 4 months, not enough time for a real change in volume of a nodule, so you're not going to see much difference, and you want to allow enough time for there to be something discernible to happen. So I think 6 to 12 months, there's no risk to the patient of overlooking something. You have an alternative explanation for why she might have that image. So I think you're fine. I think she's fine. Are you comfortable with that?
I am, and the same radiologist read both of her images, actually, from 2015 and 2016.
That's awesome. That's great. So I would give her another shot at it, you know?
Okay.
All right?
Yeah.
And it would be interesting to blind her to the original Sonos, let her read the next one, and then compare. So, but I'm just being a little bit facetious. That's not going to happen. But you do want to send her back to the same center where these were done so they can actually compare. It's very challenging. You know, these images are confusing. You know, and we all have this experience, right? The more imaging we do, the more uncertainty we create. So.
Dr. Kless, what would be the trigger for a need for biopsy? What are the things that you...
So a solid nodule that is hypoechoic, that is less echo-dense than the surrounding tissue, greater than 1 cm in greatest dimension would be, you know, is our standard indication. I tend to be a little bit more liberal and maybe like to see things a little bit bigger. Sometimes hard to hit a 1 centimeter nodule if it's deep. If it's cystic, I tend to want it to be at least 1.5 cm in maximal dimension. On the other hand, the one warning is microcalcifications within the nodule. The predictive value of microcalcifications in the thyroid nodule is probably in the range of about 80%. So microcalcifications in a nodule would make me go after a nodule even smaller than a centimeter sometimes.
Thank you.
Okay.
Thank you.
So we're a bit late. Okay, last issues, otherwise we'll see you in 2 weeks. Okay.
Evan,
okay.
Could you post that a cord extension study so we could see it?
I'm sorry, couldn't hear you.
Okay, you mentioned a cord extension study done recently. Any way to post a link to that so I can read it?
You betcha, we'll put it up.
Great, thank you.
Okay. All right, we'll see you all. See you, Ken.